India, home to more than 1 billion people, it is also home to the neglected tropical disease Kala Azar. The disease has many names: Kala Azar, Kala Jwar, black fever, dum-dum fever, and its medical name visceral leishmaniasis, or simply VL. No matter what it's called, Kala Azar is very much a disease of the poor. 15-year-old Naina has Kala Azar. Naina lives in Bihar state, northern India, home to more than 100 million people and the epicenter of Kala Azar in India. Half the world's cases of Kala Azar occur in India, and 90% of those are in Bihar.
जब काला जार का बुखार आया मुझे ठंड लग रही थी, भूख नहीं लग रही थी और मेरे पेट में दर्द हो जा रहा था और मैं चल रही थी तो चलने का मन नहीं कर रहा था, लग रहा था अब मैं गिर जाऊंगी.
More than half of Bihar's population live below the poverty line and are among India's poorest and most vulnerable. The importance of education is therefore well understood in Bihar, and this plays heavily on Naina's mind.
उसके बाद मैं 2 महीने तक स्कूल नहीं गई, मैं छुट्टी उसमें लगा दी हूँ. यूँ तो मैं और सोचकर दुबली पतली हो गई हूँ. मैं हमेशा सोचती हूँ कि मेरे को अभी मैट्रिक का एग्ज़ाम देना है और मैं पढ़ नहीं रही, तो कैसे पास होंगी. मैं जब यहाँ से ठीक होकर चली जाऊँगी तो मैं पढ़ाई में बहुत मन लगाऊँगी, कम से कम 8-9 घंटा तो ज़रूर पढ़ूँगी मैं, तब तो आगे बढ़ूँगी ना, तब तो पास होंगी ना.
At the London School of Hygiene and Tropical Medicine, Dr. Saqib Burza explains Kala Azar.
So Kala Azar is one of the most neglected tropical diseases. It exists in specific areas, specific regions in the world: South America, East Africa, and the Indian subcontinent. Essentially, it's a disease of parasites, which is transmitted by a sandfly. The sandfly tends to reside inside and around the domestic area of the house, and especially prevalent in areas where there's poor quality housing. As such, it tends to be a disease of the poorest that affects the poorest and the most marginalized and vulnerable in society.
Dr. Temi Sunioto works with Médecins Sans Frontières in India.
The symptoms that may arise is, first of all, fever, and the fever should be prolonged, meaning more than 2 weeks, and then also the patient starts to have a loss of appetite, leading to the weight loss, and eventually a swelling of the internal organ, like swelling of the spleen and swelling of the liver. And all that. In the end, this Kala Azar will reduce the immunity of the body, so eventually the patient could die due to any other infection.
Dr. Pradeep Das works with RMRI, the Rajendra Memorial Research Institute of Medical Sciences in Bihar's capital, Patna.
In India, it is caused by Leishmania donovani, a protozoan parasite. But in the world, there are many species, about 20 species, which causes leishmaniasis, but mainly are cutaneous, but Kala Azar causes visceral leishmaniasis. And in India, practically in Bihar, it is most common public health problem.
Kala Azar is almost always fatal if left untreated. Naina has come to the MSF-run Kala Azar ward at Sadar Hospital in Hajipur in Vaishali district, Bihar.
जहाँ जहाँ आदमी बोल रहे हैं, जहाँ जहाँ डॉक्टर दिखाने के लिए तो हम वहाँ पहुँच रहे हैं. हम लोग ठीक होने के कारण ठीक हो जाएगी. बच्चे ठीक रहता तब ना माँ बाप को अच्छा लगता है.
There are many challenges working in an area like Bihar. Bihar is one of the poorest states in India, with some of the poorest health indicators and the poorest literacy rates. An estimated 56% of the population lives below the poverty line and for the most part are dependent on the public health system to receive quality treatment. But with a dysfunctional public health system, the population is forced into the private health system, which is largely non-allopathic, consisting of rural health practitioners without formal medical training.
Also, as a result, there's quite a lot of cost incurred to these patients. So these patients who are already extremely poor then incur sometimes catastrophic costs in order to achieve inferior quality treatments and diagnoses.
Ganesh Paswan, who was treated more than 4 years ago, knows only too well the long and costly road to diagnosis and inferior treatment.
जैसे हम यहाँ से ताजपुर के तरफ थे, मोरिया चूड़ा मिल में थे, वहाँ पे हमको बुखार लगा। मालिक को कहे जे भाई हमको बुखार लग रहा है, मालिक ने हमको गोटी ला के दिया, मतलब 5-6 दिन लाके गोटी दिया, फिर भी नहीं ठीक हुआ। तो देखे जो मतलब रात में सोने वक्त हमको इतना पसीना बादू देता था, हम सोचे जी बादू किस लिए देता है। वहाँ का डॉक्टर सुई लगाते लगाते थक गया, वो बताते ही न थे कि मैं वहाँ से मालिक को बताए जी हम यहाँ ना ठीक होंगे, मैं जा रहा हूँ अपना घर पे।
Ganesh was soon misdiagnosed with malaria and received injections for several days. Injections that each cost the equivalent of a day's wages. The doctor then suggested a blood test, another expense.
उनके ठीक बोले जो पैसा इसमें लगेगा 500 रुपया। उनके जब हम ठीक हो जाए तो इसमें क्या है, उनको 500 रुपया दिए, खून टेस्ट कराए, तो यही से रिपोर्ट ये दिए बना के डॉक्टर साहब जी आपके पास में कल आ जा रहे हैं।
Ganesh was given a week's supply of pills and had to return every 7 days for another week's supply. He was also told to avoid strenuous work for a year.
तो हम साल भर नहीं काम की तो ससुराल वाले से कर्जा लेते थे, गांव वाले से कर्जा लेके जो भाई हम ठीक हो जाएंगे तो काम करेंगे तो दे देंगे। तो गांव वाला से 10,000-15,000 रुपया ना लेके खाते थे। तो इस वक्त में मजबूरी में हमको काम करना पड़ा, और बच्चे को देखे कि अपना जान को देखे, और बच्चे के लिए अपना खुद जान को अथी करने लगे। तो काम करते करते हौले 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 करके मतलब आधा पीठ खा के महाजन को देने लगे पैसा। फिर भी अभी भी हमको अभी इतना करते भी 25,000 रुपया पड़ जाए।
Despite the seriousness of Kala Azar, it remains a neglected disease. Many believe this is simply a matter of location. Not only does Kala Azar affect the poorest regions of India, but it affects the poorest people within those states. It is, according to Dr. T.K. Jha, one of the unjust characteristics of Kala Azar.
Take the history of Kala Azar. I say that this is one of the most undemocratic diseases because it affects the poorest of the poor.
Without a strong political voice, the marginalized and most vulnerable are left to compete with what are considered more pressing health concerns, namely tuberculosis, malaria, and HIV. In a resource-poor setting like rural India, the ability to focus on a disease that affects only a subset of society is impossible. As with so much of their lives, those with Kala Azar simply become casualties of circumstance. There is also the financial issue, according to Dr. Suman Rijal from the Drugs for Neglected Diseases Initiative, DNDI.
There is no incentive for the current pharma industries to invest in making better tools for treatment of Kala Azar. So till about a decade ago, we were still using treatments which was introduced in the 1940s and 50s, the sodium antimony gluconate. It's only in the last 15 years when there has been a few champions who have come out and really pushed the agenda.
One of those champions was MSF, an organization that has always had an interest in neglected tropical diseases. For MSF, working in Bihar was a natural fit, and by the early 2000s, finding a less toxic, less time-consuming, and an easily accessible treatment for Kala Azar than what was currently available became a priority. The move away from the toxic and increasingly resistant sodium stiboglutamate, SSG, had begun, and other drugs and combination therapies were being used. Sodium antimony gluconate, pentamidine, miltefosine, paromomycin, and amphotericin B.
A new drug in the West that had been identified for the treatment of fungal infections in cancer patients, something called liposomal amphotericin B, which is in fact it's a different version of an old drug called amphotericin B, which it's a different formulation which allows it to be given in a higher dose over a much shorter period and is far less toxic. This is a drug that was recognized as an appropriate treatment for Kala-Azar, much safer and much more effective than the alternate treatments. As such, MSF decided to intervene in order to develop the evidence base that would allow policymakers to consider liposomal amphotericin B as the most appropriate treatment for Kala-Azar in the Indian subcontinent.
Dr. Nina Slima from MSF in Barcelona was involved in MSF's Kala-Azar project in Bihar from the beginning.
So what we really proposed in 2005 was to start a project treating the patients, a large cohort of patients with the best treatment available, which is liposomal amphotericin B. This was the best treatment option because it was the most effective treatment and the safest, so it could be used for all age groups and also for women in childbearing age.
However, there was reluctance to accept MSF's proposal. The use of liposomal amphotericin B, what was to become known as ambisome, had not been proven at a large scale. The drug was expensive and it required cold chain. The feasibility of using ambisome was not looking promising.
I heard that there is a project submitted to Government of India and Government of Bihar by MSF for treatment of Kala-Azar cases. But it was not been passed at 2005. In 2006, I presented this project to Ministry of Health and Family Welfare. At that time, the NBDCP people came to Patna and they said that whether you really want to be a partner of this. We said, okay, we want to be a real partner of MSF. And then we submitted again in 2006. They asked us to some modification. Again, I presented in the Health Ministry Steering Committee. And this project was then sanctioned in 2007 in partnership with MSF and RMRI.
2 years of negotiations followed, but only when MSF could show that it could lower the price and prove the effectiveness and safety of patients did they get the green light.
So we started to treat the first patient in 2007, the 16th of July. The first child was treated in a hospital in Hajipur in Vaishali district, which was one of the highly endemic districts of Bihar state. And we could do it thanks to doing a partnership with a research entity, Indian research entity. So RMRI was one of our major partnerships. They allowed us to import the medication, to set up properly the project, and we were collaborating with them so that we could possibly publish our data and try to establish the influence we wanted to make in India to switch the protocols.
As the work continued and various combinations of miltefosine, paromomycin, and ambisome were used, evidence began pointing towards single-dose ambisome as the most effective and beneficial first-line treatment.
This is when MSF decides to do a study with the NDI to show it at a large scale, so the different combination modalities and the single-dose ambisome, which was really what MSF was supporting because it's a single point of care, so the patients can come and be treated with fatal disease like Kala-Azar in 1 to 2 hours of hospitalization or at primary healthcare level. So either at hospital level, at community level, which is really increasing the access to these populations.
By December 2013, MSF could prove the effectiveness of single-dose ambisome. They showed a 98% cure rate of Kala-Azar, a reduced hospitalization cost alongside the reduced hospitalization time, and an increase in the access to healthcare.
Well, the benefit of this new treatment would actually will have impact to the patients, because the patient used to have to first undergo various different diagnostic before finally diagnosed with Kala-Azar, and in the end, when they are diagnosed with Kala-Azar, they have to have treatment that are either having a very bad side effects or have to make them hospitalized for quite a prolonged period. So even a day of having to go to the hospital and being hospitalized will mean a lot in terms of the loss of their income.
All those involved in Kala-Azar in India, Bangladesh, and Nepal began pushing the WHO to recommend single-dose ambisome as the first-line treatment to Kala-Azar. Success came when the treatment protocols were changed in September 2014.
It's one long-awaited change, I would say, in the treatment protocol, and I think this is going to be a crucial game changer in terms of finally controlling the disease in one of the most high-burden center of Kala-Azar in the whole world.
Back in Azar Hospital, nurses prepare single-dose ambisome for Naina. The treatment is given intravenously over a period of 2 to 3 hours.
यहाँ आने के लिए इमरजेंसी डॉक्टर साहब ने बोले और इलाज के बारे में अभी मैं नहीं जानती। डॉक्टर साहब तो बोले थे 1 ही दिन आने के लिए, उसके बाद शाम को छोड़ देंगे। दवा मिल जाएगा, मैं ठीक हो जाऊंगी तो घर चली जाऊंगी।
Naina gets comfortable and her treatment begins. Thankfully, 55-year-old farmer Jageshwar Rai was referred to the Azar hospital.
तो वहाँ हम ओम प्रकाश कर गए, पुत्र साथ में था। वो हमको धरा कर दे गया, हाथ पकड़ के चलने में भी नहीं हम सकते थे। बहुत ही निछतर का तेज है, आपको एकदम तुरंत तक कलाजार पकड़ा है, यहाँ आ गए से हम आज देते हैं कागज़ बना कर चले जाइए सदर हॉस्पिटल में से आपको वहाँ खाना मिलेगा और बढ़िया ढंग से इलाज होगा, हैं से वहाँ चले जाइए। भर्ती के बाद में इलाज चला। रात में हमको शीशी जो पानी होता है पीला करके वो हमको चढ़ाए, बस देखने का हम टन टन बोलने लगे। हम पुराना कहानी इनको कह देते हैं। देखिए कालाजार हुआ हम लोग भैंसी के साथ है, मतलब बगल में खाट बिछा कर सोते हैं और गंदा उंदा रहता है तो हम कितनों होश में रहते हैं, लेकिन हमको ये गोबरे से धरिए उपतनती है। सब चीज़ अच्छा लग रहा है अब पहले हमको जहर लगता था मैडम। बहुत आदमी को इलाज हुआ है अलग अलग से, लेकिन सदर हॉस्पिटल में हम ही गए हैं सर। सदर हॉस्पिटल में वहाँ हमको पैसा नहीं लगा, मुफ्त इलाज में। कितना डेट कर गया, हमारा भाई एगो चचेरा डेट कर गया, पहलवान इतना मोटा था तो उस टाइम में ये दवा भी नहीं था, विदेशी दवाई नहीं था, वो डेट कर गया।
But medication is simply one part of the triangle that is Kala-Azar. Former MSF doctor and now part of the Kala-Core consortium, Dr. Bernard Benker explains.
So it's a vector-borne disease. So basically you have 3 important parts. You have one is the patient or the host, then you have the parasite, and then you have the vector, which is the sandfly, which carries the parasite. So you have to intervene on each level, and exactly that makes these vector-borne diseases like really difficult to eliminate, let's say. It depends also entirely on the host. In India, we have the advantage that it's believed that human is the only host of the parasite. So we think if we just like find and treat every single patient, we should be able to control the disease.
Finding patients can be as simple as going door to door. This is where Ashas, or accredited social health activists like Kishto Devi, play a crucial role. Ashas are community health workers employed by the Ministry of Health to actively identify and screen likely patients and raise awareness about Kala-Azar.
MSF के बारे में बहुत जानते हैं, उन्हीं लोग को ट्रेनिंग दिए हुआ है, हम लोग पूरा जानकार हुए हैं। क्या क्या करना है, कैसे बालू मक्खी होता है, पैदा कहाँ रहता है, बुखार कालाजार जो होता है से कौन चीज़ के काटने से होता है, सब हम MSF के द्वारा ट्रेनिंग मिला है तो हम लोग के जानकारी हो गया है। तो हम लोग जानकारी हो गया तो हम लोग जाके रहे घरे घर, तो लोग को हम कहते हैं 100-150 घर घूमते हैं, घरे घर जाके पूछते हैं कैसा है, किसी को बुखार तो नहीं है, कोई की बुखार है अगर तो जाकर स्वास्थ्य केंद्र में दिखावे, ब्लड व्लड जाँच कराएँ। जैसे कि यहाँ में जाँच में आया कि कालाजार पॉजिटिव है तो लेके जाते हैं हाजीपुर।
Kishtal Devi has another way of spreading health messages about Kala Azar. She sings.
झूठ बोले खटमल काटे, ऐसे खटमल से ना डरियो। जैसे कि हमको गाना अच्छा लगता है, हर चीज़ पर हम गाना बना लेते हैं। क्यों डरियो बालू मक्खी से तुम देखते रहियो। अगर हम गाना गाएंगे और गाते हैं तो लोगों को लगता है कि इस तरह से बालू मक्खी काटने से बुखार लगता है, यहाँ रहता है बालू मक्खी, मच्छरदानी में सोना चाहिए, ब्लड जांच कराना चाहिए। हमको जानकारी तो हम कह देते हैं कि ऐसा सब बात है, हमको जानकारी। मैया तोरे पियरी चढ़ाइबो, मोर रानी बेटिया के बुखरवा छुराई द।
In addition to running the Kala Azar ward at Sadar Hospital, MSF supports 5 primary health centers or PHCs throughout Vaishali district, including on the river island of Raghopur. In this remote setting, MSF staff conduct an IEC session, Information, Education and Communication, to inform villagers about Kala Azar, how it is contracted, its symptoms, and how to receive treatment. In villages such as these, the unsanitary living conditions are obvious. So too is the proximity of animals and animal waste to humans, and the general use of thatched housing. When combined with the abundance of water and high humidity, you have ideal conditions for sandflies to live and breed. Ramchandra is the government nurse at the Raghopur Primary Health Center.
कालाजार यहाँ अधिक गंदगी से, बालू मक्खी से होता है, और अभी तो कालाजार के विषय में पब्लिक जान गए हैं कि 2 सप्ताह से अधिक होने पर बुखार और कालाजार का शंका है और पीएचसी में जाना ज़रूरी है, और पीएचसी आते हैं तो उनको इलाज होता है।
If a person presents at a primary health center or PHC with a fever, the doctor may suspect Kala Azar. The doctor will then recommend an RK39 test, a highly accurate, rapid diagnostic test for Kala Azar.
हम उनको RK39 करते हैं, फिर लेटा करके उनका एस्प्लिन देखते हैं। एस्प्लिन अगर मिला, RK39 पॉजिटिव हुआ, तो हमने उसका इलाज शुरू कर देते हैं एक सिंगल डोज में। ये सिंगल डोज बहुत अच्छा लग रहा है, मरीज को भी सुविधा मिल रहा है और मरीज तुरंत क्योर हो रहा है।
Apart from diagnosis and treatment, controlling the vector is equally important.
How is that done? Mostly by spraying. So in this IRS or indoor residual spraying, it's also a very important activity within Kala Azar disease control, let's say. It's not only treating the patients, there's like many other things in these like kind of vector-borne diseases that you have to take care of to achieve actually elimination.
With continuing vector control, good IEC programs, and a highly successful first-line treatment, elimination of the disease is now firmly on the cards. But challenges and questions remain.
Okay, so the elimination of Kala Azar would actually just mean that the Kala Azar ceases as a public health problem. It doesn't mean that we will have a 0 case immediately, but let's say that the scope of the problem will not be as massive as it is now.
What we have to achieve is to bring down the incidence rate to 1 or less than 1 per 10,000 population at PSC level.
You have to understand, and we understand that it will be probably like more difficult that once elimination is achieved, that actually everyone keeps up the good work and the effort to sustain this elimination and not like just lays back and relaxes and then like things turn bad again.
You have to maintain good quality of indoresidual spray, you have to maintain the surveillance, you have to maintain the treatment, and all the activities which are being done today, they have to continue it.
Once a patient is cured of Kala-Azar, they could also develop a skin complication called PKDL, the post-Kala-Azar dermal leishmaniasis, which also known to be quite an important reservoir for the parasite, and then it potentially could prolong the transmission. So apart from the Kala-Azar itself that are being treated by the single-dose ambisome, there are other subgroup population of the patient that needs to be also addressed in order to achieve the elimination.
We have to also think about asymptomatic carriers, because our study from this institute first time showed that about 18% of the asymptomatic, they become the full-blown cases within 3 months.
One of the things we realized after starting the project was that we were getting a lot of patients who were coming with relapses despite being treated with this very good drug, liposomal amphotericin B. What we realized then is that a lot of these patients were presenting positive for HIV, and of whom half didn't even know that they had HIV. So we were the first people to diagnose them with both Kala-Azar and with HIV.
HIV-associated Kala-Azar, they are swarming with parasite. Wherever, right from top to bottom, you find the parasite is there. The parasitemia is more than 100 times than active case of Kala-Azar.
Co-infection itself is a real problem for both the patient and the public health provider, because these patients tend to have very poor outcomes first of all. Secondly, they tend to relapse frequently. And thirdly, when you've got a limited number of drugs to treat these patients, there's a much higher probability of these patients spreading the disease and developing resistant strains to the drugs that currently exist.
It is now the afternoon. Naina has received the ambisome and is feeling well. And just like that, it is time to go home.
मैं घर जाके अपने भाई सब के बताऊंगी कि वहाँ पे ऐसे ऐसे होता है. वहाँ पे काला-जार का इलाज बहुत अच्छा होता है. वहाँ का डॉक्टर साहब बहुत अच्छे होते हैं. फिर नर्स मैम भी बहुत अच्छी होती है. मैं अपने दोस्तों को बताऊंगी कि अगर तुम्हें काला-जार होगा तो तुम हाजीपुर सदर अस्पताल में जाओगी. वहाँ पे ठीक हो जाएगा.
The question of whether or not we're on the right track, I think the answer is yes. I think there's now, in my entire time of dealing in VL, I've never seen such a huge political commitment from across the spectrum, both from the local governments, from the WHO, from the international stakeholders, from the international NGOs. Over the last couple of years, there's been a real coming together of all the different partners to try and take these urgent steps to eliminate and control this disease. To put it simply, if we don't manage to do it in the next couple of years with all the political, financial and stakeholder support that we have, then it's going to be hard to actually do it in the future.